Hi, everyone. This is Christine Buckley with the Brain Aneurysm Foundation. And thanks all of you who are on here attending. We're super excited to get our webinar back in order. So what I'm going to do is we want to keep things timely. And I know some people probably still keep joining, but to respect everyone's time and Dr. Aries' time, I'll probably just say a few words to introduce him. And again, just thanks everyone for hopping on. This webinar is going to be recorded and we will be sharing it and storing it on our website as well. But for those of you who don't know, Dr. Aries is a neurosurgeon at NorthShore University Health Systems Neurological Institute in Chicago and the surrounding suburbs. He's also a clinical assistant professor at the University of Chicago Pritzker School of Medicine. He specializes in treating aneurysms and other diseases of blood vessels of the brain, stroke, and complex spine problems. Dr. Aries completed his medical degree at the University of Vermont College of Medicine in Burlington, Vermont, and his residency and fellowship at the University of Pittsburgh Medical Center. And Dr. Aries is not only a talented and wonderful surgeon, but he's somebody who really cares about his patients, gives back, attends the local walk run in Chicago, giving his time to this webinar. So I'm really thrilled that we have him. And I just want to say, welcome, Dr. Aries. Thank you for giving your time and being here with us tonight.
Oh, thank you, Christine. Thank you for having me to talk with everybody. I'm really excited to kind of do a little bit of teaching here and also to work on sharing some stories of patients I've worked with and hopefully kind of help some of our participants and our attendees and some people in the future kind of deal with the idea and the process of dealing with a ruptured brain aneurysm. I'm going to kick it off with a PowerPoint presentation we got together right here. I know we've got a chat going, and if anybody has any questions or any while we're going, please, you could pop in there, or else we could just kind of do everything at the end. Again, today we're going to talk a little bit about just brain aneurysms in general. Next slide. Oh, there we go. We're going to talk a little bit about brain aneurysms in general. We're going to talk a little bit about the signs and symptoms of a ruptured brain aneurysm, building off of a recent blog post that I actually wrote with the Brain Aneurysm Foundation. And then we're going to talk a little bit about what it's like to have a ruptured brain aneurysm, which I know maybe some of our participants have gone through, and what I think that some people in the future may go through, and this may be kind of a guide to help them through what is a pretty terrible part of their life, but something that I think we have really good options to help people out with. Okay, so we're going to start off with the 5 W's of brain aneurysms. So usually who, what, where, when, why, but we're going to kind of mix it up a little bit. So what, where, who, to, what, to. So starting off easy, what are brain aneurysms? So brain aneurysms are very simple. They're a weakness in the wall of a blood vessel. Okay, they commonly occur at kind of branch points once the carotid artery has made it all the way through the neck into the base of the skull. We can be born with them. Okay, they can be a result of trauma. They could be a result of infection, but in most people, it's mostly a result of the flow of blood being somewhat a little bit turbulent in an area where there may have been some mild injury to a blood vessel. And that injury can be something that we don't even understand, the results of high blood pressure, the results of smoking, things like that. Aneurysms can come in a number of different shapes and sizes. They come in kind of a saccular type, or we kind of call berry aneurysms. Sometimes they're very broad based, where the neck of the aneurysm coming from the vessel is almost the same size as the aneurysm itself. Sometimes it's a kind of a generalized dilation of the blood vessel. The thing that we worry about with aneurysms is not that someone has one, okay, but that what is the risk of it causing a bleeding event, bleeding into the area around the brain that we call the subarachnoid space, and making people really, really sick. Aneurysms, we usually find an area we call the Circle of Willis, which is basically the base of the skull, okay, where the carotid arteries come into the bottom of the skull, and we find them right in that area, okay, in places called the anterior communicating artery, the middle cerebral artery, on the internal carotid artery themselves, and then sometimes in the back part of the brain, the blood vessels that come from our vertebral arteries, which are the two blood vessels that kind of are paired in the back part of our brain that bring blood to the back part of the brain. Who gets brain aneurysms? Realistically, anybody. Anybody can get a brain aneurysm. Probably about 2 to 3% of the population have an unruptured brain aneurysm, but we do know that certain people are at a little bit higher risk of developing them. People who have had a family history of multiple relatives with aneurysms seem to be at a higher risk of developing a brain aneurysm. Also, people with a very specific type of kidney disease called polycystic kidney disease have a higher risk of developing brain aneurysms than other people do. Who should worry about a rupture of a brain aneurysm? Well, realistically, anybody who has or has a known brain aneurysm should be aware of what the signs and symptoms of a bleeding event are. Sometimes people will have aneurysms that we as neurosurgeons work with them about and decide we're just going to keep an eye on this. Okay, this is not a concerning aneurysm. It's not a high risk of rupture aneurysm. But even still, if you're having someone observe a unruptured aneurysm, you should be knowing what the concerning signs and symptoms are. The risks of having a brain aneurysm rupture, or so causing what we call a subarachnoid hemorrhage, is probably about 1% per year of life, okay? But this varies greatly between different people. We don't know what exactly causes these aneurysms to bleed, but we do know that there are risk factors, okay? Large aneurysms, aneurysms in the back part of the brain. Females tend to be at a slightly higher risk of having aneurysms rupture. Cigarette smokers, we know, are associated with a higher risk of bleeding. And people with blood pressure problems like hypertension have a higher risk of having an aneurysm bleed. Now, this is a little bit of a loaded question, what to do about a brain aneurysm. It's very easy. If you've had a bleeding event from a brain aneurysm, that aneurysm needs to be fixed. That it requires immediate medical attention. And if you think that you have an aneurysm that has had a bleeding event, you need to get immediate care at a hospital where someone can take care of you. Unruptured brain aneurysms are a little bit more of a complex discussion. Sometimes we decide that someone is at a very low risk of having a bleeding event from a brain aneurysm. Perhaps it's small, perhaps they're older, perhaps they don't have any other risk factors, okay? And sometimes that fixing an aneurysm may carry a slightly higher risk than the aneurysm itself carries to them. So we decide to watch them. Sometimes we find a unruptured brain aneurysm in a person, and we think that the risk of fixing it is probably worth taking that risk because the risk of it causing a bleeding event in them is much higher, okay? So anytime someone has an unruptured brain aneurysm, we always recommend that you sit down with a neurosurgeon, who talk to you about your specific risks of having this aneurysm bleed, and then they can make recommendations about if this should be an aneurysm that we watch, or if this is an aneurysm that we think about repairing. And repairing comes in all shapes and sizes as well, and we'll discuss that a little bit later on in the talk. So I mentioned that if someone happens to harbor a brain aneurysm that we're watching, they should be very, very aware of the signs and symptoms of what a ruptured brain aneurysm is. And so recently I worked with the Brain Aneurysm Foundation, and we put together this blog post that kind of talks about what the difference would be between a regular headache and a brain aneurysm rupture headache. And I should say that headache is pretty much the symptom that you should be the most looking out for, because headache is pretty much the cardinal sign of a rupture of a brain aneurysm. Now, usually that headache is severe, it's sudden onset, and sometimes we call it a thunderclap headache, or we refer to it as the worst headache of someone's life. It usually comes on from a kind of a 0 to 100 miles an hour, happens very quickly. This could be a sign of a brain aneurysm rupture. You have something like that happen, you get seen in an emergency department immediately. It could also be the sign associated with a number of other neurological problems, all of which require medical attention. And so if you have a thunderclap headache, or the worst headache you've ever had in your life, it is worthwhile to get evaluated in an emergency department. Other symptoms that we can see associated with the rupture of brain aneurysms are a little bit unusual symptoms for a headache. Normal headaches typically don't have neck pain or stiffness. They don't have vomiting. They don't have progressive drowsiness or changes in people's mental status, even loss of consciousness or signs of a stroke. Things like that are very, very concerning, and if associated with a headache, are pretty convincing that you should get some medical care, because that may be a sign of a ruptured brain aneurysm. And the other thing that we think about is that people who have had recent headaches. Now, just having a couple of headaches in a week is not necessarily a sign that you have a brain aneurysm, but what we do find is that people who have had brain aneurysm ruptures sometimes have what we call a sentinel headache, which would be that they have a headache that happens a couple of days beforehand that could be a sign that they have an impending rupture event. It's awful hard to say, if every headache or which headaches are sentinel headaches, but it's also something to look out for. Something we think about would be kind of a pattern of headaches. And these can be important clues in diagnosing someone with an aneurysm rupture. So if you have symptoms that you're concerned about, the best answer is be seen by a medical professional, get seen in an emergency department, let someone do a CT scan, a CT angiogram scan, so we can figure out what's going on and if you have a problem that needs to be evaluated. Okay. We're going to move on to a kind of a different part of the talk. Okay, I'm going to talk a little bit about ruptured aneurysms and the experience of patients who have them. I know that a number of people here may have gone through this, and some of this may be very familiar to you. Unfortunately, some people in the future are going to be finding this, and they're going to have themselves or a loved one who's in this very situation. And I find when I'm taking care of patients and patients' family members who have ruptured aneurysms, it's a remarkably overwhelming situation. It's a huge change in someone's health status. Okay, it is a extended hospitalization, and it's very hard to kind of have a great idea about what's going on because there's so many moving parts in a hospital in the ICU. My wife and I had a baby about a year ago, and I could tell you right before, or not right before, but for the 9 months before we had the baby, this book was sitting on our coffee table, and I won't lie and say I read the whole thing, but I'm pretty sure my wife did. But I'd like maybe this part of the talk to be a kind of a what to expect situation. Okay, something that someone in the future, when they have themselves or a loved one who is dealing with the aneurysm rupture, here's what we talk about. Here's what we're worried about, and here's what you're going to go through for the next couple of weeks in the hospital, and perhaps couple of months to years of life as you're dealing with this particularly kind of scary health situation. Whenever I talk to my patients and my patients' families about aneurysm rupture, I tell them these three facts, okay? And I don't do it to scare people. I do it to convince them that this is a pretty major medical problem. If you make it to a hospital with a ruptured aneurysm, you're already doing better than about 20% of people, okay? Because about 20% of people who have an aneurysm rupture die before they can ever make it to medical attention, okay? If you make it to a hospital, okay, something on the range of 20% of people have a severe enough neurological injury that they die during their hospitalization. That's terrible. That's a huge number, and I promise you we're doing everything possible we can to make that number as low as possible. What I can mention is over the past 20 or 30 years, we've seen that number go down from about 40% to somewhere about 20%. So we're making great moves in that direction, but there's still a lot of moves we have yet to go through to get us to an even lower number. Okay? And if you survive an aneurysm rupture and you survive a hospitalization, unfortunately, it's not quite over yet. 50% of patients will still have some neurological symptoms about a year out from their aneurysm rupture. So there's a lot of work to be done, okay, but that is work that can be done. Okay? When I describe to patients and to their family members what to expect during a hospitalization for a ruptured brain aneurysm, I tell them we break it into three phases, okay? Our phase one is what we call our emergent life-saving procedures, okay? And we're going to talk about that a little bit. Phase two is our urgent life-saving procedures, fixing the aneurysm, okay? And phase three, and what typically ends up being the longest phase in someone's hospitalization, is observation and watching for something we call vasospasm. And we're going to talk about kind of what that is, right? I'm going to dip in and out of the story of my patient FR, okay? And I'm going to use her experience to kind of tell a little bit of a story about what you should expect during a hospitalization and during a course of dealing with a ruptured brain aneurysm. Okay. FR is a 59-year-old woman. Okay, she was a smoker for about 40 years, but she really didn't have any significant medical problems. She was driving her car one day, and actually, I think she was going to get a COVID vaccine when she experienced what we call the worst headache of life. Okay, she had the symptoms we talked about earlier: a 0 to 100 terrible headache. Okay, and she began vomiting. She knew immediately that there was something wrong that was going on, and she called an ambulance. Okay, and she was brought to the hospital, where she had a CT scan and what we call a CT angiogram, which is a contrast-based study that looks at the blood vessels of the brain. And what those diagnosed, okay, is they diagnosed a subarachnoid hemorrhage, so a bleeding event from an aneurysm, okay, and an aneurysm that is associated with a middle cerebral artery. And what you can see there is her CT scan, okay, and what you can see, I don't know if you guys can see my my pointer here, but you can see that there's a circumferential white thing, okay, that's the bone of the skull, and you can see the gray stuff in the middle, which is the brain, and then you can see asymmetrically here over on the right side, and radiology things are flipped, you can see more white stuff, okay, and that white stuff is the blood that came from the bleeding event from the aneurysm. You could also see that there's some blood in between the lobes of the brain as well. So that's what happens. The blood doesn't just kind of stay in one spot. It can kind of go everywhere around the brain. Okay, so as we always do, we admitted her to the hospital, to the ICU, okay, where we kept her blood pressure under very strict control, because that's always the first thing that we do when someone shows up with a ruptured brain aneurysm. We know that having blood pressure that's running out of control can cause rebleeding events, cause it to bleed again. So we keep very strict blood pressure control, okay. Now, while she was in the ICU, FR began to get kind of sleepy. She wasn't as responsive when we would talk to her, okay? We had another CT scan that shows she was developing something we call hydrocephalus. And hydrocephalus is a fairly common problem in people who have brain aneurysms rupture. What hydrocephalus is it's a backing up of the normal fluid pathways in the brain. The blood itself that came out of the aneurysm starts to block those pathways, kind of like hair in a shower drain. Okay? If you get hair in the shower drain, the fluid starts to back up. And when you get blood in the drainage pathways of the brain, the fluid starts to back up. Okay? And unfortunately, our skull is a fixed box. Okay? And if the fluid backs up, the pressure starts to build up. And hydrocephalus is that buildup of pressure. Okay, it makes people sick. Okay, they can start getting vomiting. Okay, they can start getting very sleepy. Okay, they can go into a coma from the blood pressure being high. So phase one of everyone's hospitalization is determining whether or not they need something like a life-saving procedure, like an external ventricular drain. Okay, about a third of people who present to the hospital with subarachnoid hemorrhage need to have an external ventricular drain placed at the bedside, usually in the ICU, okay, to take the pressure off of their brain. Okay, what we typically do is we make a small incision in the scalp, a small hole in the skull, and we pass a catheter into those fluid spaces, and we drain the fluid through this catheter, okay, to keep the pressure in the brain down to save someone's life. Okay, so that's what our phase one is, determining whether or not someone needs any sort of emergent life-saving procedure like an external ventricular drain. Okay. Once we've passed phase one, then we move on to phase two, okay, which is urgent life-saving procedures. Okay. We need to fix this aneurysm to make sure that this aneurysm does not bleed again. All right, because bleeding again, okay, we know is associated with worsened medical outcomes in a ruptured aneurysm. Okay, oftentimes a surgeon will want to obtain an angiogram, okay, prior to recommending a plan for fixing the aneurysm. An angiogram is similar to the CT angiogram that we talked about earlier, except it's a slightly more invasive test where the dye, instead of going in an IV in the arm, we actually push through small little catheters that we put in the blood vessels of the neck, usually either starting from the wrist or through the leg, okay, to take very, very clear pictures of these blood vessels and get a much better idea of how this aneurysm is shaped, okay, and understanding what the blood vessels around this aneurysm look like, okay. Once we have that information, and we don't always need that information, but once we have all the information we need, we oftentimes make recommendations about how to fix this bleeding aneurysm. The two main ways we think about fixing these bleeding aneurysms are either surgery, okay, what we call microsurgical clipping, okay, where we make an incision in the scalp, remove a small portion of the skull, okay, and split the brain to find that aneurysm and put a small little metal clip across the base of it so blood can't get into it anymore. It's almost like a little metal clothespin, although much smaller than the ones you're probably used to. Okay. The other way we fix aneurysms is by fixing them from the inside out. Okay, we go up through the blood vessels. Okay, similar to how we do a diagnostic angiogram we talked about earlier. And we put one of those little small catheters inside of the aneurysm itself, and we pack it full of little metal coils or specialized stents sometimes, okay, to make sure that blood can't get into it. The end result is the same. If blood can't get into the aneurysm, it can't get out of the aneurysm, and we reduce the risk of having another bleeding event from the aneurysm. Right? Back to my patient FR, we brought her and we did an angiogram test. And what we found is what you see right here in red. Okay, we found that she had an aneurysm of the middle cerebral artery. Okay, and that's what you can see right there in the red. Now, after we placed her external ventricular drain, she woke up significantly. Okay, she was able to sit down and have a conversation with us and her husband, and we were able to talk about what our options were and what we thought we should do. Okay, we felt that this aneurysm itself was fairly amenable to fixing through the blood vessels by doing a coiling procedure. So that's what we did. Okay, we went up there under general anesthesia with monitoring of her brain and brain pathways while we did the procedure. And we brought little plastic catheters up all the way into the brain, and we found this aneurysm. We filled it up with little metal coils to keep it from bleeding. And that's what you can see on the second picture, is you can see that you don't see that little windsock shaped aneurysm anymore, where you can see a little shadow there. And that shadow is all of those little coils that are packed into it. All right. Once you've passed through the fixing of the aneurysm stage, we move into what we call phase 3, okay, or the observation phase. Okay, this ends up being the longest phase of the inpatient hospitalization. Okay, the average patient who comes to the hospital with a ruptured aneurysm spends 20 days in the hospital. Most of that spent in the ICU, and a lot of that is spent paying attention to people's neurological function and working on maybe some other bodily functions that weren't working as well, that were stressed from the bleeding event of the aneurysm. Okay, I always tell my patients that the best thing we can do is spend 2 weeks being very bored in the ICU. I would want nothing more for all of my patients than we're just bored sitting around watching them for 2 weeks and not doing anything. But that's not always the case. Okay. The biggest thing we worry about after a brain aneurysm ruptures is we worry about cerebral vasospasm. And I know this is a busy slide. I'm going to try to explain kind of what happens. When we get a bruise, okay, on our arm or our leg, our body cleans up the blood, okay? And the body does the same exact thing when we have a bleeding event from an aneurysm and blood gets around the brain, okay? As the body cleans up that blood, just like it does in your arm or leg, the blood goes through different phases, okay? As you can remember, if you get a bruise, it's purple up front, and then it kind of turns green and a little bit of yellow, okay? Same thing happens in the brain, and what happens is as that body breaks down that blood, some of that yellow phase of blood is irritating to the blood vessels of the brain, and it can cause them to spasm or clamp down. And you can imagine if a blood vessel is clamping down and blood can't get through, well, all of the brain that blood vessel is trying to bring blood to can't get blood to it. And when blood can't get to the brain, that's what we call a stroke, okay? And so about 7 days or so from the bleeding event, we see the highest rate of seeing vasospasm or spasming of these blood vessels. Now, when people are admitted to the ICU and they're being treated for a ruptured aneurysm, we automatically start them on some medicines that we know reduce the risk of having vasospasm. We also, paradoxically, allow their blood pressure to rise up a little bit higher, okay? Because the idea is that when we let their blood pressure rise up a little bit higher, we kind of tense those blood vessels open, to keep them open, to make sure blood is making it past them and getting to the brain normally. Okay. We oftentimes will use ultrasound on a daily basis to take a look at those blood vessels and make sure that they seem like they're open and seem like they're doing well. And we always check people's neurological exams, keep a close eye on them and make sure they're not developing signs that their brains are starving for blood or having an impending stroke. Okay. Despite all of this that we do, okay, about a third of people will develop neurological symptoms from vasospasm. When that happens, we have a bunch of different options, okay? Sometimes we end up pushing people's blood pressure up with medications, okay, to see if we can tent those blood vessels open a little bit more. Sometimes we recommend going back in to the blood vessels, like we did when we did the coiling procedure, or we do an angiogram procedure, where we go up and we administer special spasm-reducing medications immediately to those blood vessels. And sometimes we even have to go up and bring a little baby balloon up to those spasming arteries and pop them open with a balloon called an angioplasty. All right? So that's one of the biggest things we worry about during this time. I think I have a picture here. So here we go. So on your left side of your screen, you can see, this is not a patient of mine. This is a picture I found on the internet. So you can see a patient who is, this is before they've gone into vasospasm. And you can see the arrows are showing you the blood vessels. And these are all pretty normal looking, healthy blood vessels. What you can see on the next screen on your right side is you can see those blood vessels aren't nearly as robust and full anymore. And I would imagine this patient was probably showing some signs that their brain was starving for blood. This looks to me like a patient who we may have to go and help those blood vessels open up a little bit, whether that would be giving them some medication to open up, or either having to do a little bit of a angioplasty, opening them up with a balloon. Okay? Second part of phase 3 is dealing with hydrocephalus. You remember this from before. We placed in about a third of patients an emergency drain to get the pressure off of their brain. Okay, we have to see if the brain is going to play ball and start learning how to take up that fluid again. Okay, so after a couple of days of having the drain in, most neurosurgeons will try to get the drain out. Okay, some people will just shut it off immediately and see what happens. Some people will kind of slowly take a little bit more fluid out as the days go by to see if the brain has started to take the fluid up on its own again. About 2/3 of people, the brain will, okay, after a little bit of drainage of the fluid, will start kind of pulling its weight again. We'll start taking that fluid up. But approximately 1/3 of patients who end up having a external ventricular drain placed because of their hydrocephalus will end up having to have what we call a ventriculoperitoneal shunt placed. And that is kind of like the external ventricular drain, except it's an entirely internalized fluid pathway where we essentially connect the fluid space of the brain with a catheter that passes through a little valve and through a long catheter that spills that extra fluid out into the belly. Okay, it's everything is underneath the skin, and it's a pretty quick surgical procedure, but it's surgery. Most of the time, it has to be done in the operating room. Okay, it is. We try to avoid it if possible, but oftentimes it's something that we need to do. And honestly, it's something that's great because now we get that hydrocephalus out of the way and we can work on getting that patient to rehabilitation and work on getting better faster. The other part of the phase 3 is kind of optimizing people's medical conditions, okay? A brain aneurysm does not just hurt the brain, okay? The stress of having a brain aneurysm rupture causes stress to the brain, but also to the heart, to the lungs, to the kidneys. And a lot of the time that we spend in the hospital is also working with the critical care medicine doctors in optimizing people's other organ systems that can be affected by the stress of having this bleeding event. Okay, people can have stress to their heart, okay, when the bleeding event happens, okay, and they can need some support for their heart. People can have breathing problems, okay. Sometimes people who lose consciousness and start vomiting have to have breathing tubes placed. They can develop pneumonias, okay. We have to work on getting breathing tubes out in a lot of people, and sometimes we have to work on more semi-permanent solutions for helping with their breathing. Okay, a lot of people who are in the ICU after a ruptured aneurysm can develop some problems with the salt levels in their body, and they end up not really being able to manage them. Their kidneys take a little bit of time off, so we oftentimes have to help support that. Okay, so we always have to work on people's nutrition. Okay. Getting better from a ruptured aneurysm, you're going to need to have some really good nutrition, okay? And sometimes people just aren't quite ready to eat yet, and we have to have a tube that goes through their nose into their belly to help them get appropriate nutrition. And sometimes people who aren't awake enough, or maybe people who have developed a stroke, they may need to have like a temporary feeding tube put in their belly for a short period of time, just to make sure they're meeting all their nutritional needs in order to optimize their improvement. And then sometimes infections can happen, okay? Anybody who spends an extended period of time in the hospital can get infections associated with central venous catheters or breathing tubes, or even the external ventricular drains that we place, okay? And so sometimes we have to deal with that sort of thing as well. Luckily, okay, phase 3 for FR was fairly uneventful. She did end up spending 20 days in the hospital, okay, about 2 weeks in the ICU and a couple of extra days on the general neurosurgical floor, okay. We did an angiogram on her, which is my practice, about a week out from her bleeding event that really didn't show any significant spasming of these blood vessels. They all looked pretty healthy, okay. We were able to remove her external ventricular drain, and she didn't have to get a shunt placed, okay? And she did develop an infection associated with the external ventricular drain, and we had to give her antibiotics to treat it. So no one has an uneventful course, but thankfully I can say I think hers was, for the most part, fairly uneventful. Hospitalization is not the end of the journey for almost anybody who has a ruptured aneurysm, okay? About 30% of people who have a ruptured aneurysm will probably go to rehab, okay, to continue their improvement. And usually that happens at an inpatient rehabilitation hospital. All right. Even after rehab, people can have symptoms, neurological symptoms from an aneurysm rupture that can take a while to get better. Most people, 2/3, okay, can return to work to some extent within a year of their ruptured aneurysm. But people oftentimes complain of some long-term problems with their neurological function, with some trouble with language, maybe trouble coming up with a word that they really needed to use, or executive function, kind of optimally taking care of themselves, or their memory. Okay, and in about 50% of patients, some mild to moderate problems can exist about a year out. So it is a long-term medical complex situation that is going to require, multifactorial help from the neurosurgeons, neurologists, rehab medicine doctors, psychologists. So it's a long-term process. In terms of FR, I'm so happy to say that she has done so amazingly well after her ruptured aneurysm. She did spend a couple of weeks in inpatient rehabilitation where they were focused a lot on her physical endurance. Okay, if you can imagine spending 20 days in the hospital, you are worn out. You're not getting up and getting around nearly as much as you are. So people just can't find that they have the strength in general to get up and around. And so they worked with that for physical endurance and her cognitive abilities. She was having some trouble with some communication and language, but she continued to work as an outpatient, and she and her husband tell me at this point, probably about 6 months out, that she is doing fantastic, and that for the most part, she is pretty much back to normal. She even joined us in September for the Brain Aneurysm Foundation Aneurysm Awareness Walk, and the most important thing I can say about all this is she quit smoking, which is super huge, and I think very much reduces her risk of having any other problems in the future. So that is the story of a patient of mine, but also a story of maybe a lot of people who have gone through the event of a ruptured aneurysm. And if you guys have any questions specifically that I could answer for you, any concerns you have, any stories that you want to share, I'm happy to take any questions now.
Thank you so much, Dr. Aries. And just so you know, can you see the Q&A? Because I do see three questions.
Oh, I can.
All right, yeah. So maybe we'll start with those. And just Too, I just want to make sure everybody knows that, you know, Dr. Aries can't answer anything specifically medical about a certain case or anything like that. So as long as your questions are, you know, general in nature, then he's happy to answer them. So I'll let you take a look at these.
I'll start running down from the top here. So first question is, how do you know if you might have polycystic kidney disease that may have led to a rupture? Well, so I think it's two questions. So how do you know if you have polycystic kidney disease? And that is something, so people who have polycystic kidney disease typically have some sort of renal dysfunction or kidney dysfunction. So if you've never been diagnosed by your primary care doctor with something like a kidney dysfunction, then it's very unlikely that you have polycystic kidney disease. It's a little bit of a complex question of, do we screen people with polycystic kidney disease for brain aneurysms? I think it's fairly reasonable to get what we'd call like an MR angiogram or like an MRI based angiogram to people with a diagnosis of polycystic kidney disease at least once to rule out an aneurysm, since they tend to be have an association. But there's no hard and fast rules about it, but it remains very reasonable to do so. But if you think that you have renal problems and you are concerned about a diagnosis of polycystic kidney disease, you should definitely talk with your primary care doctor. Okay. Our next question is, what is an AVM? How is it related to an aneurysm? And an AVM is a different type of disorder of the blood vessels. It is an abnormal connection between the arteries and the veins in a brain. It can lead to bleeding events, just like aneurysms can, but the pathogenesis, pathophysiology, the underlying thing that causes them to happen is very different. So that there's not an exact relation between an AVM and an aneurysm, other than they can cause fairly similar problems in regards to causing bleeding events in the brain, and they can have pretty similar presentations. The next question is, can you explain the trauma factor in causing aneurysms? I should be very specific about this. Trauma the aneurysms we see associated with trauma are what we'd call penetrating trauma for the most part. Okay, that is people who have gunshot wounds to the head. Okay, or other types of direct injuries to the blood vessels. It's pretty unlikely for like a blunt injury like a concussion to lead to something like an aneurysm. So brain trauma like concussions is not really associated with aneurysms. It's something we think about more about penetrating injuries to the brain. So gunshot wounds and things like that, which are admittedly pretty terrible. Oh, another question is, can you talk about how your appearance at arrival dictates your outcome? Yeah, so how well someone neurologically appears at their presentation is typically associated with how well they do. So people who have what we kind of refer to as a very low grade rupture event, so they have a headache but they don't have much else going on, it's very much associated with better outcomes. People who show up and they've lost consciousness, they're in a coma, that can be associated with not as good outcomes as people who show up pretty wakeful and with it. What percentage of patients who survive a ruptured brain aneurysm have another rupture in the future? Well, I would say the typical teaching is that if someone has a ruptured brain aneurysm, we typically recommend fixing all of the aneurysms in their head to make sure that they don't have another bleeding event, because we do know that a personal history of aneurysm rupture is a predictor of having another aneurysm rupture. So probably about 20% of people who have one aneurysm have more than one. And if you have one rupture, we typically recommend fixing all of them. There's another question about grading scale for determining severity. When someone presents, we call it the Hunt and Hess scale, and that typically is just a measure of how awake someone is when they show up at the hospital. And that's not as much of a patient-centric thing as much as is kind of a physician-centric thing, as we use this to kind of communicate with each other how severe someone's neurological status is when they show up with a brain aneurysm rupture. The next question is someone who had an aneurysm rupture last year, who had a surgery, who still has some daily headaches. And the question is it typical, and what causes ongoing headaches? And the answer is it can be typical. People who have brain aneurysms rupture can have some persistent headaches. People who have had craniotomies can have some persistent headaches. It is not unusual to have that happen, and no one really knows what causes them to happen. It's, there is, from the bleeding event, an injury that's done to the brain, and sometimes people don't, completely recover. And sometimes, headaches can be a very common thing that people kind of have persist for a while. I always recommend, you should talk to your surgeon. You should have a discussion. Sometimes when my patients have kind of persistent headaches after something like this, we ask them to go and see some of the neurology doctors who have, a whole bunch of bags of tricks to help people with some persistent headaches. The question is, there's another question, which is, what size aneurysm does it have to be for a doctor to recommend surgery such as clipping? It's different for different people. A person, so everybody's a little bit different. A 4 or 5 millimeter aneurysm, okay, in somebody who is a heavy smoker, who has had a family history of having bleeding events, who has had a uncontrolled blood pressure and things like that, we may look at an aneurysm like that a lot differently than we look at someone who is on the older side, who we know it hasn't changed at all in a couple of years. So it's very patient specific, and I always recommend you sit down and you speak with a neurosurgeon about your risk factors for having an aneurysm have a bleeding event, and kind of make that decision there. The next person has 2 brain aneurysms, which are small. Is there an ideal blood pressure to maintain to prevent a rupture of a brain aneurysm? We typically just think about trying to keep normotension, which is something that our primary care doctors are great at. We try to keep people, in that range of 120/80, which is a nice healthy blood pressure ratio. We just want to make sure that people don't have very high runaway blood pressure. Next question is dizziness, lightheaded, imbalance after ruptured aneurysm surgery normal for patients with a ventriculoperitoneal shunt? And it is not abnormal, okay? But it can happen. But if you're having symptoms that are persistent, that are certainly getting in the way of living your daily life, you should certainly talk to your surgeon, and you should make sure that there is nothing wrong with the ventriculoperitoneal shunt and things like that. And sometimes, like I mentioned to the person who was having persistent headaches, sometimes we utilize our colleagues in neurology to help us kind of optimize people's problems that they're having. Question is, are there any statistics available on the recurrence of aneurysms, new aneurysms, after treated subarachnoid hemorrhage? I think this question is, okay, so what I can say is this. I don't know of the data supporting if people developing new aneurysms, so aside from the one that was fixed after subarachnoid hemorrhage, but there is about a 10% rate of recurrence after coil embolization of aneurysms. That'd be pretty normal to see. That may need a kind of a retouching up at some point down the line. Okay, next question is, how long is the general recovery for a ruptured aneurysm? Months or years? Do you know when it won't heal anymore? I usually tell patients that where they are a year out from a ruptured aneurysm is they probably won't see a ton of improvement after that, but it's possible. But that first year is when we really see people make their biggest strides. Can a previous history of migraines or use of migraine medicines possibly contribute to a ruptured aneurysm? Not in my experience. How long does the initial rupture continue to bleed? Typically what happens is the aneurysm has a bleeding event and then it stops. The aneurysms, by the time people make it to the hospital, are not continuing to bleed. They kind of bleed, they pop, so to speak, and then the body kind of temporarily closes off that popping area. Okay. But you can have a re-rupture, which is why we typically recommend that we fix them fairly soon, usually within 12 to 24 hours of someone presenting. If you have a ruptured aneurysm, what are your children? Chances your children may have one. There are familial aneurysm disorders. However, they're pretty rare. If you are the only person in your family that has ever had an aneurysm, I think that it's probably a pretty low chance that your children may have one. What I typically recommend to people is if they've had more than one primary family member who has had an aneurysm, 2 family members with aneurysms, that their primary relative should have screening, usually with an MRI. Regarding a thunderclap headache, is that headache weeks before? So a thunderclap headache is probably the most consistent symptom of a ruptured aneurysm. Okay, it is typically happens at the time of the rupture, and I find it very difficult to imagine someone could miss it. None of my patients ever described this to me as something that you would kind of pass up on. It's a pretty obvious headache. Is there research being done to prevent brain aneurysms? Yeah, so there's so much research being done, both in a couple of things. How to better screen people for brain aneurysms, how to slow brain aneurysms down that we know are growing, how to predict which brain aneurysms are going to bleed and which brain aneurysms are safe to watch. There's a remarkable amount of research that's being done in order to try to figure out, how to make these a thing of the past. Next question is, how is the efficacy of ventriculoperitoneal shunts monitored? Typically, people monitor those just for patient symptoms. Okay, so if a shunt stops working, people can develop symptoms of hydrocephalus. Okay, we just talked about headaches, nausea, vomiting, problems like that. That would be something that would require checking out, making sure the VP shunt is working. But typically, at least in my practice, we don't monitor ventriculoperitoneal shunts. We appraise people of what the symptoms are that they would feel if a shunt was stopping to work. And we tell them, if you have that, you should come and get it checked out. But typically, shunts don't need preventative maintenance, so to speak. Does working out and drinking coffee increases the chance of an aneurysm to rupture? No, not in my experience. I do not think that I've ever seen any information that would suggest that working out or coffee drinking would increase an aneurysm risk to rupture. There's a question about life expectancy after rupture. That is just very different depending on the person. Okay, someone who does very well after their rupture, who does not have any neurological issues, can probably have a fairly normal life expectancy. People who end up with a fairly significant brain injury, who have who can have devastating injuries to the brain, they may not have the same life expectancy, but that's very different on a per patient basis. Can I predict neurological problems after brain AVM surgery? I'm not entirely sure what that question necessarily is referring to. If you have had surgery and you don't have any problems, then I doubt that you're going to develop problems down the line. It's a better question for a surgeon in a specific arteriovenous malformation. I mentioned that people are back to normal after a ruptured aneurysm, and someone here has been 2 years out, and there's still some cognitive issues happening for them, sensitive to noise and night light and anxiety. And unfortunately, many people can be getting back to normal after a year, but it is not surprising at all to see people who still have symptoms 2, 3, 5, 10 years out. Sometimes what I do in my practice is I recommend that people see a neuropsychologist, which is they can kind of determine what the very specific cognitive issues people are having is, and recommend treatment for that. But unfortunately, some people may persist in these problems for a long time. Someone's asking, they have a number of aneurysms and they have 5 family members with arterial venous malformations. Should her children be tested for aneurysms? I think that is a little bit more of a complex question than I can answer right now. I think it is, it's probably reasonable, but I think that this person should probably sit down with their local neurosurgeon, kind of have a discussion about it. I think that there's probably a little bit more complexity to that answer than is suitable for kind of this venue. And Christine, I think I have answered all 25 questions.
I know. I think that's fabulous. So just on a side note, again, thank you for that, Dr. Aries. That was wonderful. I think we had about 40 people of the many more registered who are actually on. But the fun part about doing these webinars, again, is connecting people from so many locations. So I know there was someone on from Switzerland, somebody from Bermuda, California to Massachusetts, to in between, to Michigan. So in Illinois, obviously. So it's just super fun to be able to share this information with people coming from so many different locations. So thank you to everybody who joined us. Thank you again, Dr. Aries, for sharing your time and always being so kind and caring so much for your patients. Thank you to Luke and Neurosurgical Atlas for allowing us this platform. And this hopefully, again, so much has changed with COVID. And again, things like this are great, but at the foundation, we've been down some resources and some people, and we kind of got out of the loop of having these webinars. So this reinvigorates me and makes me ready to get back and get another one scheduled, because the information is critical to connect with people. So I just want to say thanks again to everyone who participated, but particularly Dr. Aries again for your time and sharing so much. We really appreciate it.
Yeah, no problem. I'm so happy to be here. Thank you, Christine, for having me, and thank you everybody for chiming in, and thank you for all of you who are sharing your stories in the chat as well. It's great to see everybody kind of being there for each other and supporting them. It's beautiful.
Yeah, no, absolutely. And this was recorded and it will be shared. So look for seeing that on our website. We'll post it to social, and please share it with your family and friends. So good night, everybody. Thanks so much.
Bye.
Bye.